Hello, dear friends. Today, I'm happy to tell you that I have Ms. Surbhee Soni with me, who is a board-certified applied behavioral analyst. And she's going to talk to us about autism and ABA. So, Ms. Soni, welcome to the show.
Thank you, Dr. Dhingra, for inviting me.
Okay, so let's start with the very basics. What is autism?
Autism is a broad range of conditions. It is also referred as autism spectrum disorder, aka ASD. It is mainly characterized by challenges in social skills, repetitive behaviors, speech and nonverbal communication. So when I say challenges in social skills, I would want to further break it down in a language which is more understandable to our listeners. Children who are not able to make friends, children who like to play just with themselves, children who have difficulty communicating socially to others, what they want, their needs, their desires. So that's challenging in the social skills. Repetitive behaviors where they have certain behaviors which they like to repeat over and over and over again. For example, playing with a certain car in a certain way. For example, spinning a wheel, again and again and again.
So you're not saying that a normal child or regular, a child with regular behavior would just use a toy car as a toy car and will pretend as if it's a real car, but a child with autism may play with it differently.
I wouldn't say exactly differently. They would also want to definitely play with the car more like a vroom. It goes everywhere. The regular typical kids also will do that. But a child with autism will do it in a certain way where he's going to take it, where he will show that behavior of going vroom with a car in a certain way and will repeat it over and over and over again in the same way every time he's playing with that car.
Okay.
Versus typical children who will show maybe variety of ways to play with that same car.
So flexibility is an issue.
Repetitive behavior
Okay.
is where the challenge comes from.
Okay.
I wouldn't want to, diverge to more flexibility part.
Okay. Okay.
Then speech and non-vocal communication. So when I say speech, they may have delays in speech. Like if a typical child who is 2 years old is already having one word vocal phrases, it may be there that a child who has autism does not have any speech till the age 2 years. May just have some vocalizations, by the age of two.
What does that mean?
So when I say vocalizations, certain sounds, like ah. We see children coming from different cultural backgrounds, so typically in our household, if we have a word that we use repeatedly, children may have sounds for those words because they listen to that word over and over again. They may have lots of sounds like ah, da, ba, but they may not be able to put that in a word, so that's what we mean, delays in speech or non-vocal kids.
Okay. So speech and play, you explained some of the symptoms in detail. Now, one very practical question is that how do parents know if they're observing something that's normal or not normal? Is it, at par with other kids' behaviors? And also, how would a parent identify that something is amiss here?
So it's difficult, but but most of the time it just gets overlooked because we are not aware of what to look for, especially with first time parents, they don't know, they feel that if the child is not crawling till the age of 6 months, it's absolutely okay, but we do know that there are developmental stages, there are developmental milestones that children have to reach at that certain age, which is why the developmental milestones are there, and typically when we go to the pediatrician, the first time, we are asked questions like, oh, whether the child has reached the developmental milestones, normally, so there are certain criteria for that. And I feel that if a parent sees that, okay, if my child is regularly, normally the diagnosis of autism happens at the age of 2 years to 3 years. There are some times where a child may show signs of developmental delays earlier than the age of 2 years or 3 years. And we do get the diagnosis done by 18 months, So if you see your child has a friend, or if you see the child is 12 months, and typically children by 12 months, either if not start walking, they'll start holding objects, and start standing, or maybe start taking one step, but if you see that your child is not even crawling or not even sitting up right, even by the age 12 months, maybe it's time for you to, go to the doctor and pediatrician and talk to them what's happening.
I have a question here. When it comes to motor milestones like sitting, standing, walking, they're probably a little easier to grasp. But when it comes to social skills, do you see any difference or difficulty in diagnosis when families from a different background, non-English speaking, for example, from some other country, where social skills definition may be different? So have you had any experiences like that, or what are your thoughts on that?
So an impairment in social skills, is a part of autism. Now what you're talking about is an impairment which could be a typical of any child coming from a different background. I could be socially impaired if I'm new to a country because I don't know people there. So I will be very hesitant to interact with people. I will be very hesitant to initiate a conversation with them. So that does not mean that I'm socially impaired. It will just mean that it's a new environment for me. And I'm just trying to take my time to get socially acquainted, by people around me. But children with autism have social challenges. So no matter you take them in any environment, whether it is a different country or their own country, they would still show that social impairment or social challenges within that area amongst their own crowd and cultural background or their own country versus any other country.
So in other words, it means that a child from a different background and culture will eventually catch up and will show signs of assimilation with other kids, whereas a child with autism may have more pervasive and persistent problems.
Right, yes. So if a typical child coming from a different background or in a different country comes to our country, he will eventually make friends. He will probably be hesitant before, but will eventually make friends. Now, children with autism, they do have impairment in that making friends part. It's the initiating conversation part, the maintaining conversation skills. These are their the challenges in their communication that they face.
Okay. Okay. So there are different types or severity levels of autism, right? And by severity, I mean, like, is it like a black or white phenomena that either someone has autism or not, or there are lots of gray areas in the middle?
So now, according to the American Psychiatric Association, in 2013, they merged autism disorder, childhood degenerative disorder, pervasive disorder, developmental disorder, which is not otherwise specified, which is known as like PDD, NOS, and Asperger's syndrome. So they have merged all of these 5 diagnoses into one, which is autism spectrum disorder, otherwise known as ASD. And under that one diagnosis, we have severity levels of level 1, level 2, level 3. Now, when we talk about these levels, we only talk about how much support the child requires was when he's at a level 1 versus
so it's not just
2,
diagnostic, it's with diagnostic, and it has intervention
correct
prediction also.
So when I say intervention, I mean, if I have a child of level 1 versus level 3, it's like how much support in terms of my intervention the child with severity of level 1 would require versus severity level number 3.
So for a parent who's observing his or her child, just give us an example. How would level 1 look different from level 3?
So level 1 children require very significant support.
No, how about the diagnosis first, the symptoms observed, level 1 versus level 3, what differences would you see?
So a level 1 child will be pretty much non-vocal, some vocalizations, of course.
Like proper speech is very limited.
Is not there or very, very limited. When we say non-vocal, they may not have words, but they may have a lot of sounds. And versus a level 3 kid may have words, but may not use those words in a context. Like they may randomly say a lot of things, but they may not have words where they may have a lot of speech, they may be able to express their desires and needs and wants with 1 word or 2 words, or maybe 3 words.
The speech may be awkward.
Not really, no, but they may not be able to have like a maintaining conversation skills like you and I are doing, they may not be able to initiate a conversation. They may have a lot of words and a lot of sounds. They may be able to put words in sentences also, but they would not know what to say and when to say. Like for example, if I want chocolate, they may not be able to express that and can I get a chocolate? They may be able to say, I want chocolate, but then they may not have variety of those, they may not have a lot of vocabulary, in their speech. Like the variety of communication skills they may not have, but they are very high functional. Severity level 3 kids versus severity level 1. With 1, we work since they need a very significant social support. When we plan treatments for them, we work and we start from the very basic. Versus if you work with a child with severity level 3, who do not require very significant support, but may just require support, our intervention plans with the child is based on we build it on his current repertoire. When I say repertoire, his current skills. What is it that he can do versus what he cannot do?
Okay. All right. So, Ms. Soni, let's talk about your specialty. What is applied behavioral analysis?
Applied behavior analysis is a science that helps discover what is happening in your environment that is affecting your socially significant behavior, which means socially acceptable behavior. It's a science that helps us discover that.
Okay.
When I say discover, it's a science that helps us see that.
So what is a socially significant or acceptable behavior?
You and I are talking right now, having an interview. This is socially significant behavior. Your presence in my environment, and I start to run around the entire house, screaming, shouting, just by your appearance, may not be socially significant.
Or appropriate? Okay.
So in a very simple language, that's the difference. And when the science of ABA comes, it helps us identify that what is in the environment that is affecting the behavior. It is still a very evolving science. There are lots of people who don't really know what the science is, including myself, until I was exposed to ABA a few years ago, and I started working in the field as a registered behavior therapist myself before I became, the board certified behavior analyst.
So what's actually done? Like, is this a diagnostic process? Is it a treatment? Could you just describe what exactly is ABA in simple words? Like, if a parent is watching this program, I want him or her to know that if they have already discovered that their child has some signs and symptoms of autism or even being on the spectrum, and they know this term, applied behavior analysis, what should they make of it? What is it in simple words? And I mean, you told us about the science, but then what do they do about it?
So ABA uses functional communication skills training as a very major part of its treatment plan, wherein we teach children or individuals with autism how to functionally communicate with their environment.
Okay, so suppose a parent has observed poor speech, some repetitive behaviors in the child, then what does the parent do? Call someone and fix an appointment, and then let's go step by step and figure out how would the parent actually, what he's going to do to help the child. So let's go step by step.
So in order to get ABA as a treatment strategy, as a technology, which helps, with functional communication skills. Parents first need the diagnosis of autism. The primary diagnosis of autism is important for any parent to be able to get ABA services. That diagnosis will come from psychiatrists like yourself, neuropsychiatrists, psychologists, and once they have a diagnosis, which is primary autism, that's when they are referred to ABA providers.
Who makes the referral?
The doctors make
Okay.
the referrals, the ones who do the initial assessment of diagnosing an individual with autism.
Okay, so then the next step is, whom do the parents call if the referral is made?
So there are so many ABA providers, depending on where the parent is, in what state. they are in. They will, sometimes the doctors will refer them out to a specific provider, and they can definitely go and get in touch with that provider. Typically, they call up, they fill up the, the initial intake process, and then they start getting the services. That's when once we have, it's a process. They take the intake comes in, they contact the ABA provider. The ABA providers get it through their insurances, because depending on whether you get approved by your insurance with ABA services or not. So once the process is all done, and we know that it's time and you are approved with the ABA services with your insurances, then the parent gets in touch with a BCBA like us. And we BCBAs then do the initial intake. We will, when I say initial intake, that's more like getting to know you, getting to know your family, getting to know the child, getting to know what are your concerns, what are the priorities, what are the areas that you want to target about. So that's where it was more like an introduction.
So where is it done? Is it done in your clinic, or is it done at home? Where is it done?
Typically it's done at the centers and the clinics, if if the ABA provider has one. These days, thanks to COVID, we are doing a lot of telehealth. So sometimes we do end up taking intakes, over Zoom meetings. But ideally, it's important for, I think, practitioners like us to do any kind of these introduction, preliminary intakes in person, with parents present, the child present, individual with autism, in case it's not the child there, so that we're able to directly observe.
Okay, so how long is this assessment process? How many sessions does it take? How long does it take?
Typically, I would say 2 hours. Some special cases it might take 3 hours. When I say special cases, where there are maybe language barriers, where there's a lot of information, that we are trying to gather during that one meeting.
Okay, so let's talk about a child, say Jack.
Right.
You've done the assessment. He has very limited speech.
Right.
He doesn't make eye contact with you, and he has these repetitive behaviors.
Right.
You've done your assessment. What's the next step?
So once the assessment is done, we make a report based off of what we have observed, based off of what the parents have, told us. Once that report is made, typically the report takes 2 weeks, I would say, for us to make the report, because we have to make sure that we cover all the areas while we're making the report. Once that report is made, we send the report to the funding source, which means the parents' insurance. Once that report gets approved by the funding source, that's when we determine the schedules. And our reports will have the recommendations of the hours of ABA required for the child, based off the observations, the whole introduction intake process that we did. So we will have our recommendations in place.
What are your criteria for accepting a case? In what situations, in other words, you will not accept a case after the report?
Every child who has, or every individual rather, who has been diagnosed with autism, comes to an ABA provider, we will accept it. If we have, like if I have the caseload, which allows me to accept another client, I will accept it.
But based on behavior, you will not exclude the child?
No, based on the diagnosis. If you're diagnosed with autism and you're approved ABA hours and you've been recommended applied behavior analysis as a treatment, we will accept it.
Okay, so once the child is accepted, then there's a treatment plan.
Right.
Okay.
And that's where this whole process of building that treatment plan comes, where we first get to know you, get to the intake process, that comes to report writing. During our report writing, we will give you recommendations of hours based on the severity levels. Also, that's where the level of severity level comes, where whether we are recommending a child 40 hours worth of ABA therapy or 12 hours of ABA therapy during
12
the
hours
week, in a week.
in a week. So that's a
Right.
very extensive
Right.
work.
So whether the child requires 12 hours of ABA versus the child requires 40 hours of ABA, which is it's intense because which is where the severity levels come.
Right. So walk us through this 40 hours requirement. Like, how is it done? So it means all day you will be working with just one child?
So we have therapists, you know, so once the BCBAs do the assessment part and recommend certain hours, you know, let's just say I have taken an assessment and I have recommended 40 hours for a particular child, then those 40 hours will be divided amongst some therapists.
Oh, okay.
You know, it's more like an 8 a.m. to like 3:30 p.m. schedule for a child, you know, or 9 a.m. to 4 p.m. kind of a schedule, you know, but the child who has been recommended 40 hours will get applied behavior analysis, like an ABA therapy, via the behavior therapists who are trained in ABA during their daytime hours.
So please tell us, like, suppose this child, Jack, now he's just started treatment.
Right.
What would the first few sessions look like? I mean, just play it out as if, you know, this is actually happening. Jack is here. He's been accepted a few hours, you know, a week. How would you start the process in the first few sessions? What do you do? What do you expect?
So every child who has been diagnosed with autism have their own unique strengths and challenges. So when we talk about ABA treatment, it's very individualized, you know, as per the need of the child.
Every child is different.
Every child is different. Every child comes with its, as I said earlier, own strengths, own challenges. So when the treatment is made, we make the treatment on what is the skill set or the knowledge the child already has.
Mm-hmm. The strengths.
You know, it's like, yes, what are your skills? What are your strengths that you already have? You know, most of the time our treatment, you know, is based out of that, you know, and first few sessions pretty much are more like pairing sessions, more like getting to know the child. If I'm a therapist working with a kid, what are his interests? What is he like? What is he doesn't like? If it's in his environment, then I would like to, I as a therapist would like to know his environment, you know,
like home.
like if it's a home-based session, then I would want to know what is it what are the places, do you like to play hide and seek? You know, does you like to play cars? Do you want to play ball? Also depending on the age of the kid I'm working with. I mean, I will not be able to work with, treat the child who's 2 years old versus 18 years old the same at
I
the
was
same
going to ask you
level.
that based on the age. How does your office look like? Are you dealing with a 5-year-old child versus a 10-year-old child? Is your office like a typical office, or is it like more like a play area?
So when we say, it all depends on the treatment plan. So we will not have, as I said earlier, that every child and every treatment is very individualized. So my 15-year-old kid will have very different programs in place versus my 2-year-old or 5-year-old, you know. Also depends on how, you know, what are the needs of my 15-year-old versus what are my needs of my 5-year-olds, you know. So based off of their needs, we will develop those programs.
Okay.
You know, so they're definitely, And based on the programs, our therapists then, implement those programs that are already in place for these two different kids.
So every kid is different, their needs are different. What would you say about the duration of treatment? Like first few sessions, of course, will be introduction, getting to know each other. What's the long-term scenario, the plan? How long is it needed for?
So our goal is to obviously discharge a client. Our goal is to not forever provide any kid APA. That's, I think, every BCBA's goal, at the end of the day. But how soon and how quickly we will be able to terminate or discontinue services depends on how much of a progress the child is making during those programs that are already in place. There are some kids who show significant improvement with the programs in place, and we keep fading our recommended hours. Like, for example, if a kid starts with 40 hours, and over the period of 6 months, typically that's what the authorization period lasts. Every authorization period typically has 6 months, and if I have a kid who starts with 40 hours and within that 6 months, he's made significant improvement in his treatment plan and has been able to meet all his goals, his targets, then when the time is for us to bring the new auth, we fade the treatment hours. And then we determine based off of the data that the therapists collect, based on the data the BCBAs collect during the supervision hours, based on the data the parents collect, and based off of the report that they give it to us, on how much of the improvement is there. It's a very data-oriented science.
But are there specific goals, or it's more fuzzy, the goals?
They're very specific goals. Every kid has very specific goals. Like if I am a child and if I have, my need is to be able to ask, demand what I want, then my lesson plan will have basic NANs in place, which is the first verbal skill that we teach kids. So that's very specific to my need.
Okay, so give us an example. A Jack, 10-year-old boy who started therapy with you with all those symptoms that we just discussed. What would be a goal for this kid, and how would you know, okay, he has attained this goal and now we can think about the next step, either terminate the therapy or send him somewhere else for further treatment? How would you set a goal for a child who has very limited speech, no eye contact, and has these repetitive behaviors?
So how will we determine a goal is based off of the assessments that we will do when the child first comes in, during that initial intake process that we are doing, So that's when we will determine the hours. That's when we will determine that, okay, you know what, this kid is at the severity level 3, severity level 1 or 2. So that's when the goal is determined.
But what would be, give an example of a goal in this child?
So 10-year-old, non-vocal, minimum eye contact or no eye contact. We would start with, I would say maybe is ranging from severity level 1 to 2, depending on how is he expressing. We will start with something like basic NANs. We will work on his verbal skills by introducing some amount of speech. Echoics will probably be one of his lessons, where we're when I say full echoic, we give you a sound and then the kid repeats the sound. So initially with children who have no vocal, they were non-vocal, we start with initiating with and reinforcing. When I say reinforcing, giving praise. Reinforcers could be anything. Could be a social praise, could be an item that he likes or a candy that he likes. So we initially start with reinforcing any sound. And the reason why we do it is because we want to tell the teacher, we want to let the children know talking is fun. It's just so much fun to bring those words out, to be able to talk. So we start with imitating any sound that's coming from their mouth, and then repeating the same sound and expecting them to repeat the same. For example, if a kid says la 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 la, I would say la 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 la, and I would expect the kid to say la 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 again. So just to let them know that, hey, la 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 is so much fun. So you're vocalizing, and gradually we pair, every object, every item, every activity in their environment with a sound.
This is very interesting, the specific techniques and how you actually work with a child. I would definitely want to cover that in our next episode on what exactly you do, how you do it. But before we end this program today, I want you to tell us one of your success stories. I mean, you don't have to, of course, disclose, who your patient was, but just tell us briefly or vaguely what made you feel good about ABA in your personal experience.
What made me feel good about ABA? I think that the little improvements that I, as a BCBA, see, and I, as a therapist, see every single day. I had a kid who we've been working with some time. I had a kid I worked with. Initially, this was when I was a therapist, and working in the field. I had a kid I was working with, and initially we took some time getting to know each other and pair each other. When I say it took a little time, it was more like I go to their house. It was like a home-based session. I go to his kid, and this kid is like, he was severity level 2, I would say. Would express a lot of things, and he would look at me, and he was like, not really want to work with me, basically. I don't know whether he hated me at that time, I don't know, but I felt that over the time, it took me at least, I think I would say 2 weeks to pair with him.
Excuse me.
Bless you.
Mm-hmm.
But I think one of the sessions, after I ended the session, it was time for me to leave. This kid comes and tells me, oh, Miss Surbhee, can I get a hug? And that made me feel that the fact that I'm being acknowledged and the fact that he's used his words, it was amazing. It was an achievement for me. It just made me feel so special.
Wow. So it's not about big changes, even small little changes, improvements, modifications can make you feel good about the whole process.
Ecstatic. I mean, even if my kid holds the cup and drinks water independently with no help from the therapists, that's an achievement. That's time for us to celebrate.
On this note, Ms. Surbhee, I'll thank you. You have given us a lot of important information as an introduction to this whole process of ABA. we'll meet again and we'll talk more about the specific techniques, your challenges. You told us about the success story, but also what challenges you faced and more information for parents about the resources. We'll talk more about that in our next session.
Sure. Thank you.
Okay. Thanks a lot.